Welcome to the Radiology Review Podcast, your on-the-go source for radiology education with your host, Dr. Matt Covington, a board-certified radiologist. Please follow the podcast on Twitter @RadRevPodcast. Send emails to theradiologyreview@gmail.com or visit the website theradiologyreview.com.
Welcome back to the Radiology Review Podcast. On this episode, I will continue our discussion of ovarian masses with a focus mostly on ovarian neoplasms, including malignant ovarian masses. I will make a free downloadable study guide on this topic available, which you can download on my website, theradiologyreview.com. Without further ado, let's get into the questions and answers for this episode. First question. What are some of the imaging features of an ovarian cyst that raise concern for malignancy? When you see thick or numerous internal septations, papillary projections, or solid components within an ovarian cyst, you should be concerned for potential malignancy. Larger size of the cystic lesion is also something that raises concern for malignancy. Complex cystic and solid adnexal masses are concerning whether they are unilateral or bilateral, including masses with thick septations. And a thick septation is something like a septation that is greater than 3 millimeters in thickness. Also, look for cystic lesions with solid nodules, mural irregularity, papillary projections, and predominantly solid masses with internal necrosis. Next question. What ovarian findings can be seen with a molar pregnancy? A molar pregnancy often presents with a snowstorm or cystic appearance of the uterus and may have associated findings of ovarian hyperstimulation with theca lutein cysts or ovarian metastases. Other things to consider for the core exam are that if they give you a history of hemoptysis with molar pregnancy, you need to consider that this is a sign of possible pulmonary metastatic disease. With a molar pregnancy, beta-HCG levels will be elevated. Next question. What is Meigs syndrome? That is spelled M-E-I-G-S. Meigs syndrome. Meigs syndrome consists of the triad of pleural effusion, ascites, and a benign ovarian tumor, which is commonly a fibroma. Fibromas are benign tumors that are most common in middle-aged females. Imaging of a fibroma includes an ovarian mass that is hypointense on both T1 and T2 weighted images, sometimes with a peripheral band of T2 hypointensity. On ultrasound, these will appear solid and hypoechoic. Interestingly, the ascites and pleural effusions typically resolve with resection of the benign ovarian tumor. So the treatment of Meigs syndrome would be resection of the tumor, and one could predict that the ascites and pleural effusions would subsequently resolve. Next, if you are shown a solid ovarian mass in a young child, what should you consider first on the core exam? The answer I am looking for here is a sex cord stromal tumor of the ovary. Next, if you are shown a solid ovarian mass in an adolescent, what should you consider first on the core exam? The answer I am looking for is a granulosa cell tumor. A granulosa cell tumor is an estrogen-secreting tumor, and as such can be associated with endometrial thickening due to that estrogen stimulation. Next question. What other ovarian malignancy commonly presents with an ovarian mass and associated endometrial thickening? I told you that a granulosa cell tumor can present with endometrial thickening due to estrogen secretion. The other ovarian malignancy that commonly presents with an ovarian mass and associated endometrial thickening is an endometrioid cancer of the ovary. An endometrioid cancer of the ovary is bilateral in at least 20% or possibly more of cases and has associated endometrial thickening, which may represent endometrial hyperplasia or endometrial carcinoma. This tumor is also commonly associated with endometriosis. An endometrioid cancer is associated with endometrial thickening and endometriosis. Next, true or false? An endometrioid cancer of the ovary can arise from within an endometrioma. The answer is true, although an endometrioid cancer arising from within an endometrioma is a rare occurrence. Next question. What is the most common ovarian malignancy? The answer I am looking for is a serous ovarian tumor. Serous ovarian tumors are the most common ovarian malignancies. A serous ovarian cystadenoma is the more benign version, and a serous ovarian cystadenocarcinoma is the malignant variety. These can be very large, predominantly cystic tumors with only a few abnormal septations. Serous tumors in older females are more likely to be malignant. Bilateral serous tumors are also more likely to be malignant. Ascites with an associated ovarian cystic neoplasm essentially confirms metastatic disease, and over half will have peritoneal metastases at the time of diagnosis. And that is something that is important to remember, that delayed diagnosis is all too common with ovarian malignancies. Often the first manifestation of metastatic disease is the abdominal ascites. Next, what is a classic clinical presentation of a juvenile granulosa cell tumor of the ovary? The answer I am looking for here is that a juvenile granulosa cell tumor of the ovary often has a clinical presentation of precocious puberty due to tumoral estrogen secretion. Juvenile granulosa cell tumor of the ovary most commonly presents in young females, with an age of around 12 years being typical. Remember associations with Ollier disease, Ollier, which is a disease with multiple enchondromas, as well as Maffucci syndrome, Maffucci, which is multiple enchondromas and hemangiomas or other venous malformations. Both Ollier disease and Maffucci syndrome also have an association, although it is somewhat rare, with a juvenile granulosa cell tumor of the ovary. Next, what are key features of a Brenner tumor of the ovary? Brenner, Brenner tumor. The answer I am looking for is that Brenner tumors are rare ovarian tumors that can also occur in the testes in males. These are most common in middle-aged females, and something like 1 in 3 cases will have another ovarian neoplasm within the same or other ovary. Brenner tumors are usually small in size. They often look like mixed multicystic and solid masses. They frequently have some degree of calcification. They appear hypointense on T2-weighted MRI and have a tendency not to metastasize. Next question. What is a Krukenberg tumor of the ovary? A Krukenberg tumor of the ovary is an ovarian metastasis with a characteristic signet ring morphology and is most commonly a metastasis from a colon, gastric, breast, or lung malignancy, with a gastric primary being the most common. Krukenberg tumors are mucin-secreting tumors. These account for something like half of ovarian metastases and are most commonly seen in young to middle-aged females. Presenting features include dyspareunia and irregular uterine bleeding. These are commonly bilateral. If you identify a Krukenberg tumor of the ovary on pathology, You would then need systemic imaging to look for a potential primary, with consideration as well for colonoscopy and upper endoscopy to identify a potential gastric or colon malignancy. Next, what is the most common ovarian neoplasm? The answer I am looking for is an ovarian serous cystadenoma. These are most common in middle-aged females. On imaging, these are classically large or somewhat large, often unilocular cystic lesions without wall thickening or irregularity, without solid components, and without papillary projections. A few thin septations may be present. The beak sign can help confirm that this is of ovarian etiology, and if no beak sign were seen, this would suggest something like a para-ovarian cyst. Due to potential risk of malignant degeneration, an ovarian serous cystadenoma usually is surgically excised. Next question. What is the most common malignant ovarian tumor? The answer I am looking for is a serous cystadenocarcinoma, which comprises up to 75% of malignant epithelial ovarian tumors. This is the malignant version of an ovarian cystadenoma. Imaging features of a serous cystadenocarcinoma are that of a cystic ovarian mass with at least one solid component that would typically enhance and show restricted diffusion on MRI. You may also see things like papillary projections and wall irregularity. These may be bilateral. If ascites is present, assume metastatic disease is also present, and evaluate on imaging for peritoneal nodularity and masses. Next question. True or false? Ovarian serous tumors are typically larger than ovarian mucinous tumors. The answer here is false. Ovarian mucinous tumors are, in fact, typically larger than ovarian serous tumors. Next, true or false? Ovarian mucinous tumors are more likely to be bilateral compared to ovarian serous tumors. The answer here is false. Ovarian serous tumors are more likely to be bilateral in comparison to ovarian mucinous tumors. Stated the other way, ovarian mucinous tumors are more likely to be unilateral, and ovarian serous tumors are, in comparison, more likely to be bilateral. Next question. True or false? Peritoneal carcinomatosis is more common with ovarian serous tumors compared to ovarian mucinous tumors. The answer here is true. Serous tumors of the ovary are more commonly associated with peritoneal carcinomatosis. Next question. True or false, yet again? The median survival for an ovarian mucinous cystadenocarcinoma is worse compared to the median survival of an ovarian serous cystadenocarcinoma. The answer is true. The median survival is worse for an ovarian mucinous cystadenocarcinoma by about 2 to 3 years when advanced. Therefore, the median survival of mucinous cystadenocarcinoma of the ovary is worse in comparison to serous cystadenocarcinoma of the ovary. Let's do one more true or false question. True or false? Ovarian mucinous tumors are more likely to be multilocular compared to ovarian serous tumors. The answer is true. Ovarian mucinous tumors commonly are multilocular with more numerous small cystic components. Next question. What is the stained glass appearance of an ovarian mucinous tumor? Ovarian mucinous tumors can demonstrate different signal intensities within the cystic spaces on MRI, which results from different concentrations of mucin within the fluid of each cystic space, and the result is a mixed signal intensity imaging appearance, which has been termed the stained glass appearance. Next question. What are key imaging features suggesting an ovarian mucinous cystadenocarcinoma? With an ovarian mucinous cystadenocarcinoma, you would expect to see an ovarian mass that demonstrates thickened septations, mural thickening and irregularity, solid enhancing nodular components, and a very large size, with the stained glass appearance that I already mentioned. Next, true or false? An ovarian clear cell carcinoma develops in patients with endometriosis in something like 1/4 of cases. The answer is true. In about 1/4 of cases, an ovarian clear cell carcinoma develops in a patient with known endometriosis. Also, remember that with an ovarian clear cell carcinomas are unfortunately very frequently malignant. Next question. What is an ovarian collision tumor? An ovarian collision tumor occurs when two histologically unique tumors are present within the same ovary, with no mixing of the histologies at the tumoral interfaces. When this occurs, that is termed an ovarian collision tumor. Ovarian collision tumors are a rare occurrence and most commonly consist of an ovarian cystadenoma with an ovarian teratoma or an ovarian cystadenocarcinoma with an ovarian teratoma. Last and final question for this episode. What is pseudomyxoma peritonei? Pseudomyxoma peritonei is the presence of mucinous ascites that occurs after rupture of a mucinous neoplasm. The most common cause of this is a ruptured appendiceal mucinous tumor, but other mucinous tumors in the abdomen and pelvis can also do this, including ovarian mucinous tumors. If they rupture, this can occur from rupture of benign or malignant mucinous tumors. On imaging, look for loculated fluid collections throughout the peritoneal cavity. Look for scalloping of abdominal organs, which most commonly starts with the liver. Look for omental caking, and look for a primary mucinous tumor, most commonly involving the appendix. With pseudomyxoma peritonei, bowel involvement with recurrent bowel obstruction is a late manifestation of disease. This mucinous loculated ascites can actually be fatal, and treatment often requires surgical debulking with IV and possibly intraperitoneal chemotherapy. Let's also take a moment to discuss peritoneal carcinomatosis. Ovarian tumors more commonly cause peritoneal carcinomatosis in comparison to pseudomyxoma. Peritoneal carcinomatosis can also result from many other tumors, to include gastric, esophageal, and colon cancers, as well as other cancers that include melanoma, breast, and lung cancer. With peritoneal carcinomatosis, imaging often does not depict the full extent of disease, and peritoneal involvement is typically worse on surgery upon direct inspection compared to what one can see on CT or MRI. Omental caking is part of the spectrum of peritoneal carcinomatosis and occurs when the omentum specifically becomes invaded and thickened with tumor cells. Ascites typically results as well. If you see calcifications in association with the peritoneal carcinomatosis, the first thing I would consider is an ovarian cystadenocarcinoma as the primary tumor. That is enough for now. I hope these 2 episodes on ovarian tumors have been helpful for many of you. A free downloadable study guide on this and other topics can be accessed at my website, theradiologyreview.com. I want to send a reminder that you can follow RadRev Podcast on either Twitter or Instagram to find free educational content that is posted there on a near daily basis. You can also check out more free educational materials at theradiologyreview.com, in addition to articles in the Radiology Review Journal that pertain in some way to radiology. Keep up the good work and study hard. Remember, you have to study really hard to succeed on radiology board exams, so prepare to succeed. I will catch you on the next episode. Content of this podcast is provided for informal educational purposes only for radiology trainees and radiologists. Medical practitioners, please make your own independent assessment before suggesting a diagnosis or recommending any course of treatment. This podcast should not be used for self-diagnosis or self-treatment and is not a substitute for independent professional medical care. Please consult your own physician regarding any diagnosis, imaging interpretation, or course of treatment.